Hi everyone, welcome to my channel. We are starting the rapid fire series of most important topics. For Let us start our first topic, that is DNA repair defects, that is nucleotide excision repair defect, which is xeroderma pigmentosa. Then we have is a mismatch repair defect, which is HNPCC, and then we are having a homologous recombination defect, which is ataxia telangiectasia, and also we have other, that is the Bloom syndrome, which was a recent NEET PG question. And then we have is the non-homologous recombination. In this we have is severe combined immunodeficiency syndrome, and then we have is a base excision repair, which is MUTYH associated polyposis, which has got a risk of causing colorectal cancer in future. Then the Betzow staging, stage 1. This is where there is a non-blanchable erythema without causing any breach to the epidermis, and this is a stage which can be prevented by changing the position every 10 minutes for every 2 hourly, and then also by using air or water beds. And then comes a stage 2, which is a partial thickness skin loss that involves the breachment to both the epidermis as well as dermis, and this stage has to be treated with proper wound care so that it cannot go into the further stages. Then comes the stage 3, which is a full thickness skin loss. This occurs up to the subcutaneous tissue, and this is the stage where we can also treat using the negative vacuum assisted closures, and also proper wound care has to be taken. Then comes the stage 4, which is a full thickness skin loss involving the muscle, bone, tendon, or even the joints too. And this is also a stage where we can treat with this negative pressure vacuum assisted closure. And also you should know that most important that the bed sores occur when there is a pressure of more than 30 mm, and the most common side being the ischium, then the greater trochanter, then comes the sacrum. Next important topic is the CTG, which is frequently asked, and here you should know the deceleration, which is a dip in fetal heart rate by 15 bpm for at least 15 seconds. And here first is the early deceleration. You can see that the FHR is going to coincide with the contractions, so this is seen in head compression. And then comes the late deceleration. Here the FHR doesn't coincide with the contractions, and this is seen in uteroplacental insufficiency, fetal hypoxia, and also when the pregnant lady is given an epidural. Here you need to remember that the normal FHR is going to be between 110 to 160 bpm, and the variability should be between 5 to 25 bpm. And also this dip maximum 2 minutes, it can be a difference of 15 bpm. And comes the then comes the next variant, which is going to be a sinusoidal pattern, and this is a continuous wavy pattern, you can see. And there is going to be a worst prognosis in this kind of pattern because the seen with the fetal anemia or even the fetal acidosis, and usually we cannot guarantee. And then comes the variable deceleration, and this is a stage where there is going to be no relation to both the FHR as well as the contractions. It's a kind of differential pattern, you can see, and this is seen with cord compression. And next is the sleep EEG wave patterns. As you know, sleep consists of two stages, which is NREM and the REM. So NREM is again N1, N2, and N3. So first, if you can see here, it's a beta wave. In this stage, you can see that the person is awake with eye being open, usually seen with REM sleep. Then comes the alpha waves, where the person is in a awake state with his eyes being closed, and this is seen in persons who are going to have meditation or who are in a relaxed state. And then comes the N1, which is going to be the theta waves, where they have been having a very light sleep, or you call it a micro sleep. And in this stage there is a significant myoclonic or hypnic jerks usually felt by the persons. And Then comes the very next N2 waves, which is going to be the two different kinds of things we can see in this, because it's going to be a sleep spindle, and then you have is a K complex, and this is the stage where there is going to be maximum sleep, about 45% it's going to consist of. And then comes the N3, which is going to be your delta waves, and this is where the person is in deep sleep and is also known to be a restorative kind of sleep. And then comes the very next and most important, which is nothing but your REM sleep. And here it is nothing but a beta wave, but you can see that there is going to have a sawtooth kind of appearance. And this is an important stage because at this stage the person is going to have dreams or even the nightmares which he can remember, whereas night terrors which are usually occurring at night entry stage are usually forgetful. The other important topic is the TB resistance. So here you have monodrug resistance, which is isoniazid. That is going to be next the rifampicin resistance, which is only to your rifampicin. And then comes the polydrug resistant kind of TB, where there is going to be a resistance to other drugs other than your isoniazid and as well as rifampicin. And then comes the multi-drug resistance kind of TB, where there is going to be resistance to both isoniazid as well as the rifampicin. And then comes the very next, which is the pre-extensive drug resistant TB variant, where there is going to be resistance to isoniazid, rifampicin, any of one of the fluoroquinolone drugs. And then comes the extensive drug resistant TB, which is usually the XDR TB. Here there is going to be resistance to isoniazid, rifampicin, fluoroquinolone, and also the recently added drugs to any one or both of bedaquiline or linezolid. This wraps up the episode 1 of Rapid 5 series. And if you're interested in this, we would like to make more videos, and I suggest you watching this at 2x speed. And this is the most useful and important topics for NEET PG, FMG as well as INI set. Please do subscribe, like, and share. Thanks for watching.